My name is Betty Farrell, and I'm a nurse and a researcher. And for the last 26 years, I've been a researcher at the City of Hope National Medical Center. My research over the last 26 years has focused on the model of quality of life. And so through that model, we have tried to depict that people who are facing cancer are real people who have real lives, and that people with cancer, we like to see through the lens of quality of life and think about them as whole people with physical, psychological, social, and spiritual needs. And so those are the 4 dimensions of our quality of life model, and we use those dimensions as we do a variety of research and education projects to really help clinicians to understand how best to address quality of life needs. Our approach to quality of life is always very patient-centered. So in all of our studies, whether they be quantitative, qualitative, descriptive studies, randomized clinical trials, we are asking the patient to report their quality of life across those 4 dimensions. We then use that quality of life model to also design patient education and support strategies so that we are trying to help the patient, for example, with better symptom management, better attention to psychosocial needs and spiritual needs, and also to support family caregivers who are very much a part of oncology care. We've been fortunate to conduct a number of NIH-supported and other major foundation grants that have allowed us to test quality of life interventions in a rigorous way to really support the growing evidence base, the science of quality of life research. So, for example, we conducted a study funded by NCI on how to best approach pain and fatigue management, 2 very common problems in oncology that impact quality of life. Another example is we've just concluded a 5-year program project grant funded by the National Cancer Institute, in which we focused on the population of people with lung cancer. And in that study, we did a trial testing a palliative care intervention that included components such as comprehensive patient assessment, interdisciplinary team collaboration to plan the care for that patient and family, and then structured patient and family teaching. And in each of these studies, we've demonstrated that through rigorous research, through applying evidence-based approaches, we can impact quality of life, improve symptoms, decrease caregiver stress, and really help support patients and families as they go to cancer treatment. All of our research over the past 26 years that I've been at City of Hope has included family caregivers as a key component. So for example, in our program project grant that we just concluded in lung cancer, one of the entire projects was devoted to family caregivers, and we included family caregivers of stages 1 through 4. People with lung cancer. I have another study going on now funded by the American Cancer Society that focuses on low income and underserved family caregivers. Because increasingly as cancer care moves into the outpatient setting, as we're caring for more and more older people with cancer, the role of family caregivers becomes only more and more important. The 3 components that we believe are vital to really impacting the quality of cancer care are, first of all, comprehensive assessment. We really need to know who is this patient that's before us that we're about to treat for cancer. And so conducting a comprehensive quality of life-based assessment so we really know about this person's comorbidities, their psychosocial concerns, who they live with, who they're caring for. The big picture of this patient is the first step. The second key message is interdisciplinary collaboration. When we have nurse practitioners, oncologists, surgeons, nurses, social workers, chaplains, the entire team meeting and working together to plan the patient's care, absolutely we know that we'll have more coordinated care and better outcomes. And the third component is patient and family teaching. Again, who is taking care of the person with cancer? It's the family 24 hours a day, 7 days a week. And so we really need to be good at teaching patients and families how they can best support the patient at home. The area of communication is ever growing as a focus area for everyone in oncology. In my own setting at City of Hope 2 years ago, one of my colleagues, Dr. Elaine Wittenberg, joined our research group, and she is a communications scholar. And so with Dr. Wittenberg, we are now doing a number of projects and studies to try to also advance this area of communication. What is very clear is that there's great opportunity as clinicians, whether that be nurses, physicians, pharmacists, social workers, for all of us to increase our communication skills and for us to recognize how important communication is when it comes to the outcomes of cancer care. One of the opportunities that I've had over the recent years is that because we also do a lot of training projects, I direct a national project called ELNEC, the End of Life Nursing Education Consortium, and this is a national and international training program to prepare nurses in better care for seriously ill people. As part of that project, we had the opportunity to work with almost all of the VA hospitals in the country and to train those VA hospitals in better palliative care. And I can certainly say that in that experience, we were so impressed with the excellent care that's happening in the VA hospitals and the commitment of the VAs to provide the most compassionate care for the seriously ill. And definitely the VAs are now the model for the nation. They are doing superb care of veterans who are at the end of life who really deserve excellent care.